Thank
Thank
you
you
so
so
very
much.
much. So I do receive research grant support from Alcon, but has no relevance in this particular presentation, and acknowledge the contribution of my colleagues, Dr. Deepa, Vaishali, Shail, and many others at our center. And I think, unlike the adults, as Professor Jagatram said, the objective of the cataract surgery in children first, and that is to make sure that the eye remains safe, not only on the immediate period, but lifelong in the eye. So technically speaking, we want to make eye sound. That's our first objective. If it doesn't remain, the second stage of achieving functional outcome remains a theory. So functional outcome, naturally, we want to prevent further amblyopia development and also develop the binocular vision, and if in a unilateral cataract as well, with the help of additional optical means. Why should we implant an IOL? Obviously, we want to have an early rehabilitation. The thick aphakic glasses do pose problems to the parents and children, and contact lenses in majority of our scenarios is impractical. However, whatever we do is we need to keep correcting refractive error in a growing eye, and that's what Jagatram said, help of the optometrist all the time. And why we should be concerned or not implant is because of not able to achieve bag implantation consistently in your hand. And if you cannot, you be careful. Many of these eyes produce exaggerated, accelerated uveal inflammation because uveal tissue is immature, the barrier are not fully formed, and we need to be careful. Little flutter of the iris, little iris coming to the side ports is enough to produce cell deposits and glaucoma and so on. So I think increased visual axis obscuration and need for secondary procedure, and all of these are a concern for not putting the lens. Primary implantation is the way consensus is developing, certainly in children about 2 years of age, and also perhaps in unilateral cataract at some centers and our team with some experience. However, if you leave the eye aphakic with your choice, or if you have to, keep secondary implantation in mind when you operate for aphakia. So in other words, keep the capsular support intact as much as you can, anterior and posterior, when you do a primary aphakia, and take up for secondary implantation once the child is 4 years of age. And you have a choice of bag or sulcus and transscleral or intrascleral fixation once the child is about that age. In the bag implantation, and anti-vitrectomy, as we discussed already, is mandatory in children who are very young. And we can achieve that, as we heard in the first presentation, in more than one way in the bag implantation. I'll refer to some of the studies which have reported a 10 years follow-up of infants group, and they concluded that IOL group performed worse than the aphakic group. Similarly, there is a review in the ophthalmology written by some of these authors who also concluded that IOL option is no better than the contact lens management. But mind you, in that study report, they were given free contact lenses, and the contact lens care was at even domiciliary. So I think for us, that's not very relevant what they found. And incidence of visual axis obscuration was higher in pseudophakic growths, and so was the residual refraction. The registry of the bilateral cataract removal of the infants published in 2019 by some of those same authors also concluded that the visual acuity after bilateral cataract was comparable in both these patients. IOL placement increased the risk of visual axis obscuration and secondary procedure, and also occurrence of glaucoma. So it seems that the primary implantation is okay in the children who are more than 2 years of age, but still we do not know what's the situation here and 2 years, under 2 years of age. So I'm trying to get the cursor here, right? We published a 5 years post-operative outcomes of randomized study of bilateral aphakia and pseudophakia in children under 2 years of age in American Journal of Ophthalmology. And it's not moving now here. Jankana, the thing is not moving here. My slides are not moving. Yeah, okay, got it. So we got that study with the purpose of comparing complications mainly, and then visual outcomes in that particular cohort. Post-operative complications were glaucoma, visual axis obscuration, and uveal inflammatory response primarily, and then the visual acuity. The glaucoma was defined by the conventional laid down by the experts, and we did the pre-eye and post-operative gonioscopy in all of these cases. A significant visual axis obscuration was judged subjectively, whether it was fibrous or proliferative in type, and then the secondary procedure was decided on. Synechiae formation was quite common, and cell deposits, which most of these deposits disappear within 4 to 6 months. The complication rate between the aphakic and pseudophakic group was comparable in terms of the glaucoma and visual axis obscuration, but posterior synechiae and cell deposits were more in IOL group in that study that we reported. So we concluded in that study that incidence of postoperative complications was comparable in terms of the glaucoma and the visual axis obscuration, but higher incidence of inflammatory response reflected in the synechiae formation and pseudophakic eyes. However, it didn't impact in a clinical sense and in terms of the visual acuity that they achieved. As we heard earlier, IOL implantation can be done first with the posterior capsular axis performed, and then putting the lens in the eye. And like Professor Jagatram, we prefer single piece acrysop because of its increased stability, but 3-piece is a very, very good option for in the bag implantation. This is something which we do quite often in eyes where we are not confident of performing a PCCC, and we use trocar for pars plana lensectomy. So we introduce the trocar first before we open the eye, and then through the high cut rates possible with the machine, we perform a controlled capsulectomy followed by anti-vitrectomy, and we are able to do that. Advantage here is that the in-the-bag implantation is ensured. However, performing pars plana approach is not that easy, and it needs some learning curve. The key question is, and therefore we have certain age, when will you not do vitrectomy? Because we know that vitrectomy can have a bad consequences in the long run, and also its impact on the growing eye. We don't know what will be the influence of vitrectomy in the growth of the eye, what will be its impact on the glaucoma formation and the postoperative time, and so on. So Dr. Gimbel translated the principle of optic capture into pediatric eyes and reported that in older children, and he did it in children about 5 years, that the optic capture can avoid anti-vitrectomy. So this is one example of that technique. The cataract is aspirated as we have seen earlier, and then a larger capsular axis in the posterior capsule is performed, anterior and posterior capsule, and then the optic is pushed towards the vitreous through that larger posterior capsular axis, each half one at a time. And then both the capsule, the anterior capsular axis and the posterior capsular axis are in front of the optic, and the vitreous phase is intact. Sometimes when you perform PCCC and vitreous phase is disturbed, you can perform anti-vitrectomy and still continue with the capture if you have adequate size. And this is how it looks, generally speaking. So we did that study, a randomized study again, whether the optic capture can avoid antivitrectomy. So we had published that in journal JCRS in 2017, and we compared the complications in children up to 4 years of age having conventional surgery versus optic capture without antivitrectomy. And we randomized that. We could not perform capture in 5 out of 31 eyes. 3 eyes had a plaque and 2 eyes was too big a rhexis. And we had to perform vitrectomy in 2 eyes, but all of these eyes did quite well, and 3 had IOL in the bag. The visual axis obscuration in both the groups, group 1 in the bag and optic capture at 12 months, 24 months, and 36 months were comparable with not significant in terms of the statistics. And same thing, below 1 year versus 1 to 4 years, also there was no difference in between the 2 groups or between the 2 eyes. So same thing was reflected in uveal inflammation, was identical, whether we did vitrectomy or we did capture without vitrectomy. The cell deposits were comparable with no significance. So we concluded in that optic capture randomized study that 3-piece hydrophobic IOL it's possible to capture in majority of the cases, and visual axis obscuration and glaucoma, and also inflammation, which was a little surprise to us. We expected more inflammation in the capture group because of the capsular fibrosis that can occur, but they were identical at 1 year follow-up. So this is an alternative surgical technique which can avoid vitrectomy. And however, this technique has a flaw. It is not easy to perform, and there are eyes where you will end up in a mess if you are not able to control the size. And also, it's very difficult to perform this under 6 months of age. In our study, we had the patient under 6 months, and that there were not many, fortunately, but it is not easy to perform this capture under 6 months of age. So I think, summary, if I have to say, the adult cataract surgeons who are willing to take up the pediatric cataract in their management plan need to gain confidence first by operating and managing older children. The team will get the experience and confidence, and then take up the younger children. But think before you take up a child less than a year, and certainly under 6 months of age, because under 6 months, the complication rate is high in everybody's hand. Primarily, the difficulties in the intraoperative, the uveal trauma and the uveal inflammation, and equally in the glaucoma. So I would caution, in general, from a podium, to suggest implantation under 6 months of age for these cataract surgeons who do not have the right team and a long-term experience. So thank you very much for your patient hearing.
Thank you very much, sir. This was just excellent presentation and very right advice given, because everybody thinks that they are the pediatric ophthalmologist and pediatric cataract surgeon and start implanting IOL in less than 6 months and come up with several of the complications. Whereas we people are also very selective in implantation of IOL under 6 months of age, sir.
Right. Thank you. Thank you, Jagat. I agree.
Dr. Sumita and Dr. Vashini, one by one, what is your general message in the same way for particularly in infants? Do you do an IOL or would you leave the child aphakic?
For me, I think it is an anatomical decision, honestly speaking. Because in an institute, I do have all the team as mentioned by Dr. Vasavada. I do have pediatrician, I do have anesthetist, I do have a support hospital to transfer the babies. So that decision is, and I've been doing for 15 years now. So the experience is there, but still there are some children I would leave aphakic. if I'm not sure that they are going to come back for follow-up. Lot of us get, I'm sure Dr. Jagatram also faces that issue about poor follow-up. So sometimes if I'm not sure about the follow-up, I don't put the IOL. Unilateral cases, I do try to put the IOL as much as possible. But bilateral cases, I do sometimes leave them aphakic if I'm not sure they are coming back for follow-up. That I'm talking strictly about 6 months and below. So, and of course, as I said, decision for me is anatomical. If the axial length is around 18 or more, corneal diameter is 10 millimeters or more, I would plan for an IOL.
Thank you, ma'am. Varshini?
Yeah, I completely agree with ma'am. But again, I don't have the same level of support which you get in an institution. So if it is a younger child, say less than 6 to 8 months with a lot of systemic issues where you think anesthesia might be complicated, I tend to refer them to a higher center, especially with AIMS so nearby. And they generally tend to come back for a follow-up. So I think that even in anesthesia, if you think that there are multiple other systemic issues happening, especially cardiac issues, then I think those are the children we need to be very cautious about.
Thank you.